Okay, hi. I know lots of you, but if I wasn't here for the first session, so I don't know if it was done because I was flying. Can I get a quick idea of who's where? So pharmacy, we've got pharmacy people. Okay, lots, great. ID, micro, clinicians, gen med, those sorts of things. Scientists, yep, and purely academic. No, and we've got some pharma as well, I know, in the audience. So, okay, so mainly pharmacists, that's great. So I'm trying to, in this lecture, work out A, what Jason wanted me to talk about, which has been very difficult, and then B, try and encapsulate what our statewide program does over a 2 to 3 day workshop in 40 minutes, okay? So it might be a little bit hard. I was going to stop for questions and sort of feedback along the way, but I think we'll be doing a lot of that in the next session, so we might hold that. So generally what I'm going to try and do is give you a framework of how I work and how I approach a problem, and then see how you can maybe apply it to your own settings, hopefully in the next session. So just disclosures, my views don't represent anyone, and I don't know who I represent anymore because I do work across 2 health services. One for the internationals is in Canberra, which is the capital of Australia. And then in the statewide antimicrobial stewardship program, which provides direct service to areas that don't have an infectious diseases physician within their health service. So it does span quite a big area. And so I'll be using that to show you some differences in the Australian landscape. But generally what I want to cover is why are we here, yeah? And my personal bias of why we're here. I want to talk a little bit about the Australian landscape as it is and the complexity of the Australian landscape and how it interacts with what we're expected to do or what we think we're expected to do. And then how to use that to assess different settings, so where we're starting from and where you want to get to. And then work out how we improve on those risks we've identified, all those things we've identified we want to work on, and then maybe just touch on at the end what we should expect from the future, from ourselves and perhaps from the nation. So why are we here? So, I'm going to be practical. We're only here because of the standards, yeah? Okay? There would be no way in my health service I'd get a 2 FTE AMS pharmacist, a 0.9 of a physician component to run a program within my hospital. No way. So, the practicalities is we're there for standards, and as soon as they go, if they go, we hope they won't go, we'll actually be up the creek without a paddle, yeah? Okay, so unless we're showing that we're actually making gains in quality improvement, saving patient sort of stays and adverse outcomes. So really we're here for improved patient outcomes, yeah? Now, are we here for just quality and safety or something else? Something else? So I think we're here for something else, yeah? And I think that's really well laid out in the standards of Australia because there's a medication safety standard, okay? So if we were just here for adverse drug reactions, mismatch of allergies, TDM, those sorts of things, then it'd be covered by the medication standards, yeah? People may disagree with me, but that's my belief. And a lot of the stuff in the medication safety standard is actually reflected in what we think we should be doing in an AMS program. But really we're under the healthcare associated infection standard, at least in the hospital setting. And so really we're expected to reduce and control healthcare associated infections, reduce antimicrobial resistance, as well as improving outcomes, harm minimisation, yeah? So generally, I don't think we'd exist without antimicrobial resistance drivers, okay? Some hospitals will that have very progressive executives, but unless they're there, we wouldn't have existed. And so I think generally it's really imperative that anything we do, we inform all decisions, not only on quality and safety, which has to be at the forefront of what we do, but we have to have a strong focus on what we expect the outcome to be in terms of healthcare associated infection and resistance, yeah? And you should think about those things all of the time. I'm sure people will go through this, so I won't go through this in detail, but this is the new, the second edition of the standards for antimicrobial stewardship, and it's no longer 3.14 if you haven't read it. It goes into some other digits. And it's very similar. But one thing I just want to explain is that 16C talks about evaluating your program, identifying the areas for improvement and taking action to improve, okay? It doesn't actually say you have to show improvement. It just actually says you have to show action, yeah? Does anyone know why that is? difficult to show improvement. So whenever, I think the literature says, whenever you put in an intervention, the average rate of success is 16.4%. It's pretty dejecting, isn't it? Yeah. So when something succeeds that I do, I'm like, oh my gosh, you know, hitting above the average. So it's very, very hard, okay? And I think, you know, when I started in the field, I had no skills, you know. I did a Master's in Public Health, I'd done my project management, blah, 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 and I thought I had some skills, but I had none, really. And so within the work we do on a daily basis, I think it's important to have quality and safety skills, yeah, and quality improvement skills. And, you know, we should always continue to have that in our continual professional development if we're intending to work in this area. So, what is the Australian landscape? So, the answer is it's pretty good. In general, with regards to the tools, yeah? Okay, so we have fabulous surveillance tools at the moment comparatively, and we've seen, you know, South Africa doesn't necessarily stack up with some of the tools we have available, and thankfully, and I think it's only recently been put out in the public arena that, you know, these are continuing to be funded from a national perspective. So we have the National Centre for Antimicrobial Stewardship providing the beautiful NAPS portal, then we've got the Norse surveillance data, we have org tracks, and bringing it all together we have Aura. But still it lags to some degree at a national level to tell us what we're doing and what we should be doing, and so the Commission tries to help us, okay? The most recently being the memo, yeah? Has everyone got the memo? Yeah? Everyone's focusing on surgical prophylaxis? Fab. Okay. So there are external drivers that will drive what we do, and the memo is a perfect example of that, yeah? So every executive who's looking at accreditation in the next 3 to 6 months wants to know what's going on with surgical prophylaxis, okay? And so the external drivers are there for resource allocation in the form of the standards. We have heaps of in-house expertise. Just, you know, the faculty here today, you know, not even thinking about who's in the audience, there's amazing expertise. And many programs, such as the one I run, such as the ones people who've been speaking today run, are reaching some sort of maturation point, yeah? The low-lying fruit is done, and we really have to work out how to progress, but some are still finding their feet, and that often happens in rural and regional Australia. And on top of that, we have this vastly different antimicrobial usage and resistance patterns in Australia, so it's hard to know where we should be focusing. And this is one thing I just wanted to highlight to you. So I know a lot of health facilities have smaller hospitals and big hospitals. This is Queensland, okay? So, cellulitis, okay, the red bars look at how many encounters per 1,000 separations in your hospital different hospitals have, okay? And this is the population rate. So, of the hospital admissions defined with cellulitis, how many is per 1,000 population? So, you can see these are all the principal referral hospitals. Yeah, this is Queensland, so that's the state average. And these are the really small hospitals, these are the bigger hospitals, and these are the principal referral hospitals, okay? So, what impact do you think that's going to have on prescribing? Massive amounts, yeah? So the smaller hospital's going to have massive amounts of prescribing just because of the patients they see. Whereas respiratory syndromes, this is actually just the separations, I didn't put the population rate on top, has a lot of different variation, okay? And why is that? The sort of concept should still be the same, the referral, you know, drivers should be the same, but the epidemiology is a little bit different. And so if we just take one thing from one hospital setting and outlet and lay it over another, we're going to have problems because the drivers might actually be different. And of course, you know, we can see that in this small hospital that I've just put up as an example, 30% of all prescribing is for community-acquired pneumonia. In my hospital, it varies between 8 to 14%, depending on the year. And so, you know, what we do and what we focus on, because none of them have surgical prophylaxis there because they have the occasional list, is really, you know, not going to be the right focus for them. So working out how they're actually going to focus is really important. And this is just one antibiotic use change over one facility, okay? So this is oral antibiotic use in one health facility. So there's, you know, how many, 10 hospitals or something there, okay? So look at the changes. Yeah, massive. And the IV situation is similar. So the cookie cutter approach is not going to work. And resistance. We know resistance is, you know, changing everywhere, but this is sort of Queensland. And you can see that, you know, in 2013, we only had really one hotspot that had 30% more of MRSA on our antibiogram. And now we can see it's really changed. Okay, so things change, and they change quickly, and they're changing quicker than therapeutic guidelines. So we have to know how to adapt. Okay, And of course, we've got all these different programs, okay? I can tell you about different models, you can talk to me about that and many other people in the room. But essentially, at any particular hospital setting, you're going to have different drivers and you're going to have different resources and different support systems. So, how does this apply to you? And that's why we're here. Well, when I work in Canberra, I work in a facility, just one facility, I don't have to worry about anything else. But essentially, all the different settings are my wards, yeah? And when I work in health services or in the statewide program, which has a number of health services, they're all different hospitals, okay? So these concepts will apply to anyone, and it's about how you work through them. So, do you know in your program where you are at the moment? Do you know? You do. Okay, so you've read your antibiogram, you've read your usage, you know, yeah? Yeah? Have you tied it together? Yeah? Okay, so you know where you're going? Yeah? Great, okay, so that's great. So generally what we have to work towards is identifying your risks and having a plan to address them, okay? And this is sort of how I think about it. So when you're assessing your needs and your capacity for change, the things you're looking at help you identify what your risks are and then how you should approach them. So when I look at quantity and quality of usage and patient demographics of who's coming in and the epidemiology, what's being used where, and my resistance drivers, I think about risk, okay? What's my risk to my patient and where do I have to act, okay? But then you have to be realistic, okay? So knowing you have to act doesn't mean you can act, okay? So the governance of your situation, the clinician capacity, you know, your general clinicians, your ward pharmacists, you know, your doctors, etc., and your AMS expert resources will change your methodology and the time frame over which you can act, okay? And that's why it has to be different in every setting. So, risk. We talked about risk assessment. Do people have a way of assessing risk? Who's done a risk assessment for their program? Other than Toowoomba, I know Toowoomba's done all that. Anyone? Come on, Toowoomba's done one. I know, we've done one for some things. Anyone? No? Okay. So, in every health service you work in, there is a framework for assessing risk. Yeah? Who's seen them? Yeah? We've seen them, but we haven't used them. Yeah? Unless we're using our risk assessment frameworks and the protocols that they expect us to work within, we will never get heard at the higher level, okay? And so essentially in every hospital, you will have a way of assessing risk. So I'm going to give two examples, okay? So these are examples from any of the facilities we work in. But essentially I have two risks, okay? So the first one's respiratory prescribing. So in one facility, it takes up 70% of all prescriptions on our NAPS report, okay? There's community-acquired pneumonia and COPD, not talking about hospital-acquired pneumonia. A quarter of that is ceftriaxone, which is probably not uncommon, and we know 50% of that ceftriaxone is inappropriate, okay? Probably a common setting for lots. Now, unfortunately, on a point prevalence survey, we found that surgical prophylaxis was going for longer than normal. The year before it was 9%, so we were like, sweet, we don't have to worry about it, we'll just sit back and rest on our laurels for a little while. And of course, 6 months before accreditation, we get this point prevalence survey that says prophylaxis is going too long. But only 3 of those prescriptions were for ceftazoline, okay? So, what's going on there? Within the respiratory prescribing, we've just recruited a new respiratory physician who actually is from the UK, so very strong bent on antimicrobial stewardship. The general medicine director, which a lot of respiratory comes under, actually happens to be an ID physician, so pretty good buy-in there. And generally, the facility has really good knowledge about AMS because it's a sort of moderate profile AMS program. Whereas surgical prophylaxis, we have a director that says you just must fix it, yes? Doesn't understand the process of what we want to go through, and they just want rules to fix it. There's a disjointed communication stream and the clinicians really can't be contacted, yeah? Very common scenario. And it's all over the shop. It's all over the whole hospital. There's no clinical decision support. There's a healthy FTE for AMS, but there's a capped project plan to do 1 extra intervention that year because everyone's dealing with PIP-TAS, and that's the second intervention that's going to be running for the year, right? So that's a change in project plan. And there's moderate, CDF, ESBLs, a general sort of moderate to tertiary hospital setting. How do you assess which one you focus on? You've got one choice.
Risk assessment.
Okay. How would you risk assess that?
There's a look at things Consequence.
That's right. Good. Okay. Next slide. In each health service, there'll be specific criteria on which you assess risk, okay? And this is how your exec talk, okay? And this is what will put it in a framework for them. So you can look at strategic planning, you can look at delivery of safe clinical services, which is what we mostly focus on, and health service delivery. So PIP-TAS would be a big health service delivery issue if we actually ran out of that and associated antibiotics. And then financial, of course, money talks. But reputation does also. So as soon as that ORA report comes out, if you want anything done and they can work out what, you just hope a journalist works it out, yeah? Because then you're ready with your program. So you assess those things first, and then they've got, low risk, high risk, blah, blah, blah. And then you look at likelihood. So it's almost certain it's going to happen. It's almost certain we're going to run out of PIP-TAS, yeah? And then it will help you work out what the consequence is, yeah? So a lot of the things, if you were to assess your AMS program now, would be high to very high risk. You don't realise the risk you do realise the risk you're working in, but within a health service organisation, they don't understand the risk you're working within. And if you can put that in a framework for them, it's really, really powerful. And then people start to take interest in actually changing what you want changed. So for example, the PIP-TAS shortage. So essentially over Queensland, it was $10 a vial more, right? So over 8 months, that was going to cost Queensland $4 million more, yeah? So that's a really powerful concept. And then, people right up the chain will start to be involved. Sepsis is similar, the death rates and things. So once you've identified a risk, you have to work out how you're going to treat it or mitigate it, okay? They're slightly different, okay, treatment and mitigation. Risk treatment is how you're going to deal with the risk. So, if I can suggest one thing, only keep what you can control within your program, okay? Sepsis. Are you going to control it within your program? You are not going to control it within your program. You can try to get people to get the time to antibiotics in a certain thing, but if the whole system isn't working, it's a hard effort. When really, if you work together, you could be making a lot more change, okay? So escalate those things to your executive, but keep things like therapeutic drug monitoring of vein congent and all those sorts of things within your program because you can control them to some degree. And once you escalate things, people start to share the risk and you'll find resources will start to come to you. So you start to have an ability to plan an intervention with some sort of resource, okay? And this is where the art of saying no is sometimes beneficial, okay? And saying no, although it seems terrible for patient care, actually is beneficial in the long run for patient care. Because if you're doing things in an under-resourced setting, you will never make gains, okay? But if you're resourced well, then you can make gains very quickly and affect a large number of people. But ensure the data that you're escalating is actually what you need fixed, okay? So you really need to know what you're measuring. So this is where it's really important to know the difference between benchmarking or surveillance data and things like drug use under evaluation data or a more detailed analysis of a prescribing syndrome for an example. So I want to fix before accreditation for surgical prophylaxis. What benchmarking data do they get? Yeah, they get snaps if you've done that, but you need an engaged surgical service for that, so you don't even have that. So what gets escalated on your report? If you're escalating something, what dashboard do you have? Yeah, drug use? Yeah, sure. But, basically the basic program should have a NAPS report, right? And you get your annual report and the antibiotics greater than 24 hours goes to executive, yeah? You should be doing that. If you're not, just do that. But they see the dashboard, yeah? So all they hear is antibiotics go longer than 24 hours, yeah? Is that what you want them to focus on? Maybe, but if you don't want them to focus on that, then you need to give them different data, okay? So escalate benchmarking data with a little bit of, risk associated with it because they might get the wrong timing, the wrong message. So what I want them to hear is that 10 to 20% aren't getting antibiotic prophylaxis on time, okay? Because it's a much bigger patient population and that's much more meaningful for the clinician, the surgeon, rather than some antibiotics are going too long, yeah? Because it's about surgical site infection risk. Okay. And be prepared to hold your ground. So define your issues, focus on quality of care of the patient, and be prepared to focus elsewhere if you don't think all these things are coming together and they're not focusing on the right issue. So surgical prophylaxis, we were talking about too long or the timing. You have to assess the quantity, as Duncan was saying. And so try and get your figures on some paper. Risk mitigation. So you have to work out how to fix things, yeah? Okay? So you have to actually know what the cause of the problem is, yeah? And it's something sometimes we do well and sometimes we don't do well. So if you look at a problem with a solution, yeah, you should be prepared to fail. So if you go on and say, EMM's going to fix all these problems, you're going to fail, right? Because it's not going to fix your problems. Might do a little bit. But if you can attempt to blink yourself just to deal with the issue at hand rather than a solution initially, you'll actually find you open yourself to a whole nother barrage of solutions that you never even considered. When we started our AMS program in camp, well, a fully funded AMS program, we were told we would not have funding for IT, yeah? Which was ridiculous. We had so much FTE and we just wanted to use it well and we didn't have any IT. And it actually enabled us to sit back and go, where are our issues, and change how we actually restrict antibiotics. And we have a different restriction sort of bent to a lot of other tertiary hospitals, but it works, okay? So don't see a barrier as a problem. Think of it as an opportunity to think outside the square. When you try to clarify what the cause is, I would implore you not to just dump your head on a piece of paper, okay? Because every time you do that, you will be subject to recall bias for your own personal biases. You will have an incomplete map of what's going on and you won't be able to stratify which is most important, okay? So you'll think it's a prescriber, you'll think it's the Impress, the Pyxis machine, or, whatever it might be. So you have to try and find a way of doing it systematically. And there are many, many ways which, I'm sure you can, if you don't have experience in that, you can call people and get some education on that, but it's really important not to do that because there's all these issues, right? Interpersonal issues, structural issues, job satisfaction issues, group dynamics. There's so many things that if you don't think about them, you will fail. So, for example, the stock shortage on pip-taz, yeah? So everyone goes, we need more pip-taz. We don't have any coming in the country, we need more pip-taz. So that's the solution, yeah? We just need more pip-taz, yeah? But in actual fact, if you reframe it and you say the current stocks aren't enough to provide clinical care, yeah? Okay, you're reframing the situation. There's not a solution in there. And actually, when you look at it, there's a few issues, yeah? Sometimes there won't be alternative agents, Enterococcus and fungal, some sort of situations. There's an issue about supply in the fact that it's not accessible at all, so, it's just not being supplied. There's appropriate demand issues, so, where there's no other treatment options, which was pretty rare. But the inappropriate demand was a huge thing, okay? We all know it's used incorrectly, yeah? So if we had identified this issue or actioned it 3 to 6 months earlier, yeah, than when the alert came out or when we're getting signals that things were going on, we wouldn't have needed to find another distribution supply of pip-taz, right? We could have reduced our, usage by 50% for 4 months before and just ridden it out, yeah? So it's about sort of being able to convey those type of things. Okay, so you have to work out whether you're going to go ahead, yeah, with an intervention. And there are things you need to look at. You need to look at if it's feasible, if it's practical, okay? So if you think you're going to implement an AMS program with an IT system and they say you're not going to have an IT system, there's no point thinking about it and being distressed and going home and crying because you don't have the budget, When you need to look at the risks, okay? The risks of going ahead and the risks of not. So there always is unintended consequences, okay? The unintended consequences of using broad spectrum antibiotics in sepsis is that they will continue on the ward, okay? So there will be problems, but you just have to see if they're acceptable risks. You have to see if it's affordable. You have to see if it's treated to patients with impartiality, okay? So you're not going to particularly or consciously disadvantage a patient group by doing what you're going to do. It has to be sustainable, okay? You can't keep adding on things and expecting the health service to pay for it unless it's an amazing intervention. And it has to be effective and cost effective. So that sort of defines how easy it's going to be to execute something. So you need to sort of stratify what you think you're going to do in terms of that. And some of the things are going to be more important than others to do, yeah? And then once you can work out those things, you can actually work out what's most important and what's easiest and work out what you should do, yeah? So you can put it in a framework. And some things are high priority because they're easy to do and they're important. They have to be done, so you do them. But the ones that are hard to do but of low importance, you just shelve. Just put them away, don't get stressed about it and move on. The ones that are hard are the hard execution, but they're so important, okay? And those ones you have to really think about. Do you have the time? Do you have the resources? And do you have the governance structures? And if you don't, then I'd suggest trying to not pursue those things. Okay, you have to make a plan, you have to gather enthusiasm, and you have to measure, okay? Work planning, a whole topic in itself, but you need to know why you're doing something, you need to know what you're going to achieve, you need to know how you're going to achieve it, who's going to achieve it, and when by, okay? And unless you're setting those in your head or on paper, whatever you need to do for your organisation, you won't be able to get there, yeah? I'm not big on those people who say, visualise where you want to be in 2 years and, you know, you'll eat healthy and, you know, be free of cancer by having beetroot juice. But, you know, if you don't write it on a piece of paper or at least have it clear in your head, you won't get there and you'll lose focus. So I would implore you to do that. And one thing we talk about stakeholder engagement a lot, right? And we're going to go and talk to everyone, and we do, absolutely we do. But what we don't think about is how we get stakeholders on board to start, yeah? So, you know, I was talking to someone at lunchtime about, you know, private surgical prescribing, you know, and of course there's naysayers and you won't be able to move them, bricks, walls in the road. But there are ways of leveraging stakeholders, yeah? And so working out frameworks for doing that is really powerful. So one little tip I have, if you go into a meeting and someone's pro-AMS, yeah, you never leave that room without asking for something, okay? You don't go and just have a chat, yeah, AMS is great, that's right, yeah. You go in with a dedicated ask on the table, okay? Because if they're pro and you've had a 20-minute conversation about how fabulous AMS is and they're not going to give you anything, then you've lost an opportunity, yeah? The other ones are a bit harder, but always ask for something more. And you have to measure. So I'm hoping that everyone knows the SMART metrics, but they have to be there. You have to be able to define it. You have to be able to measure it. They have to be actionable, relevant, and time-bound. And that's what I was talking about. You have to know when you're going to achieve it by, because that's how you know whether you're doing well or not and wasting your time. So, whatever you do, just be prepared to fail, okay? Because 16.4% is not great odds, yeah? I hope we can all do better by being a little bit more intentional, but we have to be prepared to fail and learn. The issue is learning, and if we don't know we failed, we can't learn. But the beauty of succeeding is that then you have a story to tell, okay? And you can make it real for your clinician, and so you need to communicate them. And I think we don't do that well because we're always on to the next risk that we have to deal with, yeah? But once you can celebrate your successes, your clinicians will come on board. But also, if we are failing, you have to be prepared to stop doing what you're doing, yeah? And that's really hard, yeah? It's just really hard because you thought it was such a good idea when you started. But the things you do get along the way, even if you're failing, is you get people interested, yeah? So your collaborators and people to integrate. So one thing I don't think Australia has progressed particularly well with yet is integrating with infection control, yeah? So I heard someone's actually, their governance structures, actually they report to infection control, yeah? Okay, so it's great. Like, it's great. Some people might think it's not great, depending on your infection control unit, but the fact is that they're thinking about how this is going to integrate, and we can't work in silos, okay, because it's not sustainable and people don't want add-ons. They want to integrate it into their work. So for sepsis, if infection control's not, you know, collecting the time to antibiotic data, why are they not collecting that for you? They're going out and seeing every bacteremia in your hospital, or at least they are in mine, and they're not collecting the antibiotic data. It's a waste, yeah? You need to leverage those people. ICU, you know, you need to leverage their VAP surveillance, things like that. Retrieval systems in rural facilities. If you're not actually working out who's getting retrieved and are they getting the right antibiotics in your facility, you are missing a huge risk thing that you can escalate to your executive now, yeah? Okay, so where do we go and what do we do? Well, this is where we should get to. I can't remember where I saw this slide, but I did ask to use it. I think it was in the sepsis thing from last year in Queensland. Basically, we have to get from unmindful, unconscious sort of safety and quality, reactionary processes to generative. It just has to be embedded. So nurses don't want to hear that IV to oral switch is the most important thing they need to do on the ward, right? They want to know how it's going to integrate into my discharge planning process, yeah? How is it going to stop me having to spend 2 hours putting an IV antibiotic up? That's what they want to know, and that needs to be embedded. And we have to be proactive and actually preempt issues before they come, and we're not quite there yet. So, program assessment, moving to problem solution, and then you can start to talk about innovation, because you're starting to think of new and exciting things by not being taken into the framework that you think you're expected to do, okay? So, what will it look like in the future? Well, I think we all have to be a little less distressed about the quality and safety department, yes? People hated them, yes? And I get it, because they feel like they're an extra thing and no one knows what anyone's doing. That's because it's new, yeah? So give them time and use them, yes? Just use them. They're there. And we have to integrate. We're not going to be able to not integrate. So infection control, safety and quality, and AMS have to integrate. So that's one way you're going to leverage your program and start to get more effective interventions, because you'll have more resources. You need to start getting real-time feedback, and hopefully the Aura platform will, be a bit more responsive in the future about that for our clinicians. We need to integrate our surveillance systems, so the infection control systems, our systems. If you're collecting surgical site data, antibiotics yourself, that's stupid, They're doing HIPs, they're doing Caesars, they're doing everything. Don't do it. And what Australia, I think, has to accept is that we all should be deviating in what we're doing in our own programs as we mature, because everyone's going to be doing IV to oral switch, and everyone's going to be doing surgical prophylaxis, but then we're going to have to focus on antifungal stewardship, and then we're going to have to focus on something else. So, I think we have to start working along the same paradigm, but deviate based on our risks, but be able to communicate why we're deviating. If you can't communicate why you're deviating, then it's going to be a lost cause, because you'll fail accreditation. You probably won't, but you'll get a 90-day turnaround. And I think, the tertiary facilities are riding on the coattails of all these surveillance systems, because everything's designed for us, yeah? But you have to expect that the Commission and all the resources are going to have to actually provide things that are more responsive to smaller facility and community needs, and will be less important, okay? So we need to be prepared for that. And I think, accreditors are going to have to adapt and understand that we will be deviating from what they expect us to do, as long as we're following a framework that we can show that we're producing outcomes based on risk. Okay, so not many answers, but frameworks there that hopefully we can take into the next session. And of course, I work with fabulous teams both in the ACT and Queensland. In Queensland, many people are here. So there's our contacts. If you want, feel free to pick any email off and it'll get somewhere. And yeah, hope to see you in the next session.